Welcome to The Explainer. Today, we're doing something a little different. We're going to step into the clinic and play detective. We're going to crack 7 really common but super tricky medical cases. The kind where the first clues can send you way down the wrong path. Okay, let's get into it.
So here's the fundamental challenge, right? It's what every clinician faces. A patient walks in with a set of symptoms, but those symptoms could point to a bunch of different diseases. And telling them apart? Well, it's not just some academic game. Getting this right can literally be the difference between life and death.
So here's our game plan for today's investigation. We'll start by setting the scene. Then we'll jump into some classic cases of mistaken identity. After that, we're going to pull out the microscope to find some hidden clues, tackle some high-stakes emergencies, and then we'll wrap it all up in your final case file.
All right, let's put on our detective hats. For each of these 7 puzzles we're about to see, we've got to examine the evidence, spot the imposters, and make a final call based on that one critical clue that just cracks the whole case wide open.
Let's dive into our first set of cases. We're starting with the ones where what you see right on the surface can be incredibly deceiving. You know, the kind of thing that can easily lead to a misdiagnosis if you don't know exactly what you're looking for.
So our first case file opens up with a really common complaint, patchy hair loss. The list of possibilities is huge. Is this a compulsive habit, like trichotillomania? Maybe an autoimmune attack, like alopecia areata? Or is it something else completely? The answer, it turns out, is hiding in the hair itself.
Okay, now look closely here because this is where the magic happens. Alopecia areata gives you these really smooth, perfectly round bald patches with these little exclamation point hairs. But trichotillomania? Totally different. You're looking for messy, irregular patches where the hairs are all different lengths. That is your smoking gun for compulsive hair pulling. And the treatment isn't a cream or a pill. It's cognitive behavioral therapy.
Case number 2. A patient comes in describing this absolutely brutal, one-sided headache. It hits them in waves for weeks at a time, and then, poof, it's gone. Now, it is so easy to just jump to the conclusion of a migraine. But hold on, there's a notorious imposter we have to rule out first.
And this table just lays it out perfectly. A migraine is this throbbing pain that can last for days. But a cluster headache? Oh, it's shorter, maybe just a couple hours, and it brings friends to the party. The key question you have to ask is about those other signs. A tearing eye, a stuffy nose, maybe a droopy eyelid, all on the same side as that killer pain behind the eye. If you see that, you're not dealing with a migraine. And your first move for treatment? High-flow oxygen.
All right, for our next couple of cases, the clues aren't something you can just see. We have to go deeper, a lot deeper. We're talking cellular level. It's time to see what a biopsy or a lab report can tell us when a diagnosis is hanging by a thread.
Okay, picture this. A patient you know has lupus, starts showing signs of kidney damage. A biopsy is an absolute must, because the treatment completely changes depending on which class of lupus nephritis they have. The 2 big ones you're trying to tell apart are class 4 and class 5. So, what's the tell?
It all comes down to location, location, location. If those little immune deposits are subepithelial, that means they're on the outside of the kidney's filtering membrane, you get this classic spike and dome look under the microscope. That's class V. But if those deposits are subendothelial, on the inside, they create what look like wire loops, and that's the more aggressive class 4. This tiny difference in location, it changes everything about the treatment plan.
Okay, next puzzle. You have a patient with polycythemia vera, which basically means their blood is way too thick, and they have a stroke. Now, your first instinct might be to reach for a powerful blood thinner like warfarin, right? But is that the right move? Well, it depends entirely on what kind of stroke it was. So here's the crucial thing you have to know. Warfarin is for strokes that are caused by a clot that formed in the heart, usually from atrial fibrillation. But for a stroke caused by atherosclerosis, a ruptured plaque in an artery, the right call is antiplatelet therapy. Like aspirin, totally different mechanisms. And don't forget, for the underlying polycythemia vera itself, the main treatment is pretty simple. Phlebotomy, just removing blood, and aspirin to keep things flowing.
All right, deep breath. We're walking into the emergency room now, where the clock is always ticking. In these next cases, getting it wrong, or even just getting it slow, can have absolutely devastating consequences. These are the situations where you have to think fast and act even faster.
So, a patient rushes in with pleuritic chest pain. It's sharp and it hurts like crazy when they take a deep breath. Now, it could be something totally benign, but in the ER, your first job is to be a pessimist.
You have to immediately hunt down and rule out all the life-threatening imposters that look exactly like this. And this is basically your hit list. Does the pain feel better when they lean forward? Get an EKG. Think pericarditis. Are they high risk for a blood clot? Check a D-dimer. Think about a PE. Do you hear crackles when you listen to their lungs? Get a chest x-ray. Look for pneumonia. It's only after you've ruled out all those killers that you can finally breathe and say, okay, this is probably just a self-limited viral pleurisy. The treatment? Simple, and it SAIDs.
Oh, this next one is a textbook case. I mean, it's the classic presentation. A young, tall, skinny guy suddenly gets hit with sharp chest pain and can't catch his breath. If you see this picture, one diagnosis should be screaming at the top of your list: a primary spontaneous pneumothorax, a collapsed lung.
But making the diagnosis is just step one. What you do next is a super clear algorithm, and it all comes down to size and how stable the patient is. If it's a small collapse, we're talking less than 3 centimeters, and the patient is totally fine, you can just watch them. But if it's large, or if they're symptomatic, they need a chest tube, and they need it now. And if they're unstable, showing signs of a tension pneumothorax, that is a true drop-everything emergency that needs an immediate needle decompression.
Okay, our final and maybe most critical case. An older patient, history of bad arteries, comes in with just excruciating abdominal pain. But when you examine them, their belly is soft. That phrase, pain out of proportion to the exam, is the hallmark of acute mesenteric ischemia, a gut attack. But now it's gotten worse. They're developing peritonitis. There is only one move.
That's it. Emergency surgery. Once you see signs of peritonitis, it means the bowel is dying. There's no time to think about less invasive options like stents or clot busters. The only thing that can save this patient's life is getting them to an operating room for an open bypass and to remove any dead bowel. Every single minute matters.
Whew, okay. We have worked our way through 7 really complex cases. We've identified the imposters, we've found the hidden clues, and we acted fast in emergencies. Now, let's pull all our findings together into one final case file with the key takeaways.
Let's do a lightning round review. Trichotillomania, look for the varying hair lengths. Cluster headaches, it's all about those one-sided autonomic signs. Lupus nephritis class 5, subepithelial deposits. Stroke in a patient with PV, antiplatelets for atherosclerosis. Viral pleurisy, it's a diagnosis of exclusion. Rule out the bad stuff first. A pneumothorax, size dictates what you do. And for acute mesenteric ischemia with peritonitis, the only answer is the OR.
So as we've seen, diagnosis is part science for sure, but it's also a bit of an art. It's about knowing which single detail tells the whole story. So the final question I'll leave you with is this. After seeing all these cases today, which one of these imposters are you going to be watching for most closely from now on?